Assalamualaikum warahmatullahi wabarakatuh. My name is Siti Nurhaziqah Binti Jasni. I'm from Bachelor in Medical Imaging, part-time Cohort 7. Today I will present about hysterosalpingography, which is HSG. Okay, what is HSG? HSG is a hysterosalpingography. Is the radiographic demonstration of the female reproductive tract with a contrast medium. The radiographic procedure best demonstrates the uterine cavity and patency of the uterine tubes. The uterine cavity is outlined by injection of contrast media into the uterine cavity. The shape of and contour of the uterine cavity is assessed to detect any uterine pathologic disease. Okay, this is the anatomy part of the uterus. In the right side is endometrium, myometrium, perimetrium, vagina, cervix, ovary, femur, infundibulum, fallopian tube, and fundus. This is the indications and contraindications of doing this procedure. For indication, we do this HSG procedure for infertility, recurrent of miscarriages, to investigate of suspected incompetent cervix, and following tubal surgery, which is post-sterilization to confirm obstruction and prior to reversal sterilization. For contraindications, we do not do the surgery during menses, during pregnancy, and a prolonged discharge on inspiration of the vulva or cervix, or diagnosis with pelvic inflammatory disease in the preceding 6 months. This is the patient details. The patient name is Yong Zuan Yuan. She is 28 years old, and she want to do the procedure hysterosalpingography, and the consultant radiologist is Dr. Sherry Abdullah. This patient have come to the radiology department in KPJ Potri with the referral letter from the other clinics. She want to do the hysterosalpingography, which is HSG procedure. She have no history of miscarriages and planning to have a child after 5 years of marriage. This is equipments and instruments that needed for doing this HSG procedure. First is contrast media. The contrast media that utilized in HSG are water soluble, non-ionic contrast media. We will present it by 20 milliliter. The major equipment tools for doing this procedure is a fluoroscopy examination room. Okay, these are the equipment and instrumentation that we use in HSG procedure. First, in the right side, we have a sponge holder, uterine cannula, sterile drape, sterile glove, galley pot, syringe 10cc, kidney dish, cusco speculum, KY jelly, uterine sound, and sterile gauze and tissue. Next, this is a patient preparation before doing the procedure. First, this procedure may include proper bowel preparation to ensure adequate visualizations of the reproductive tract and unobstructed by bowel gas or feces. The patient may be instructed to take a mild pain reliever before doing this procedure. To prevent displacement of the uterus and uterine tubes, the patient should be instructed to empty the bladder before doing the examination. The procedure and possible complications should be explained to the patient before the procedure. Remove all the clothes and wear the hospital gown, if possible, shaving the genital area, and ask the consent from the patient. The protection that we use is the shield and the lid gown. The procedure planning. This procedure should be performed in the length of follicular phase of the menstrual cycle to ensure that the patient is not pregnancy and to prevent false intrauterine filling defects and proximal tubal occlusion due to endometrial thickening. Some facilities perform routine pregnancy tests prior to the procedure, but this practice results in an unfavorable cost to benefit ratio. This is a procedure planning. An epi's cut-off image will be taken. It will include a pelvic area. The centering point is at 5 cm superior to the symphysis pubis. At the beginning of the procedure, the patient will lie supine on the table in the lithotomy position. The patient will bend her knee and places her feet at the end of the table. The patient will give a thyroid shield. The patient is draped with the sterile towels and with sterile technique, a vaginal speculum is inserted into the vagina. A cannula or a balloon catheter then is inserted into the cervical canal to dilation with a balloon catheter helps to occlude the cervix, preventing contrast media from flowing out of the uterine cavity during the injection of the contrast. Once cervical placement of the cannula or catheter has been obtained, the radiologist may remove the speculum and place the patient in a slight Trendelenburg position. This position facilitates the flow of the contrast media into the uterine cavity. A syringe filled with contrast is attached to the cannula or balloon catheter. Using fluoroscopy, the radiologist slowly inject the contrast media into the uterine cavity. If the uterine tubes are open, contrast media will flow from the distal ends of the tubes into the peritoneal cavity. There are many complications of doing the HSG procedure. First, the patient will get pain from passage of speculum and injection of cannula, distension of the uterus with tubal spasm, pain on peritoneal spillage of using the contrast media persists for 24 hours, and allergic phenomena include urticaria, asthma, and laryngeal edema. The post-procedure, the patient will be experiencing in vaginal spotting and a pelvic cramp for 1 day after the procedure. In some situations, the patient should be prescribed an antibiotic from the doctor. If the patient have experience with fever, increased pain, or heavy bleeding, must contact the doctor immediately. Next, this is a radiographic criteria that should be demonstrated. The pelvic ring, as seen on an AP projection, should be centered within the collimation field. The cannula or balloon catheter should be demonstrated within the cervix. Contrast medium is seen within the peritoneum if one or both uterine tubes are patent. Appropriately density and short scale contrast demonstrate anatomy and contrast medium. The patient ID marker should be clear and the right or left marker should be visualized without superimposing the anatomy. How the HSG works? Okay, this is the AP scout image. We can see that the pelvic ring is in AP position and the center of the collimation field. There is have no radio opaque and pelvic ring have covered. Okay. In the second image, we can see that the speculum and the cannula is in profile. The contrast is filled the uterine cavities and the contrast have slightly seen at the right fallopian tube. Okay, in this image, the contrast have at the right side of the fallopian tubes, but we cannot see the contrast at the left fallopian tubes. At the last image, we can see that the contrast at the right side of fallopian tubes have exit at the distal end of the fallopian tubes, but in the left side there is no other contrast have filled the fallopian tube. For conclusion, we can see that this patient have a blockage at the left fallopian tube. It can be confirmed by the contrast have not filled in the left tube and there is no spillage of the contrast at the end of the tube. The diagnosis is left proximal tube occlusion. For the conclusions, this HSG is a valuable tool in the evaluation of the uterus and fallopian tubes. Radiologists and radiographers should become familiar with these HSG techniques, the interpretation of HSG images, and possible complications of doing this procedure. These are my references from the Google, and my presentation will be end here. Thank you.